Welcome, everyone. We'll get started in just a moment. We're just opened the Zoom, so we want people to get settled and ready to participate and listen to our webinar. Just 1 minute. Okay, let's get started. Happy New Year to all, and welcome to today's webinar on data triangulation. This is the first of 2 webinars on this topic, and I want to remind you that the next webinar will take place next week on Tuesday as well at the same time, and I'll give you more information on that later. I also want to remind you that the webinar today is being recorded, and we will share the link to the recording with you in our follow-up email. As most of you know, my name is Barbara Lampier. I'm a senior technical advisor with JSI, and I've been working for over 30 years in capacity building and supply chain management across many countries and many programs. I'm joined today by 2 colleagues to present this webinar. Adriana, please introduce yourself.
Hi, everyone. I'm happy to be here. Thanks for coming today. My name is Adriana Alminana, and I'm a technical officer at JSI, focused on their immunization projects. And I've been at JSI for just about over 7 years now, supporting immunization across different programs and activities in Africa. Thank you.
And we're so pleased to have our colleague, Timoteo, who is here from VillageReach, joining us today. So Timoteo, will you please introduce yourself?
Hi, everyone. My name is Timoteo Shaluku. I'm from Mozambique, and I work for VillageReach as a project manager. In my recent past, I worked for VillageReach, but seconded by the Minister of Health of Mozambique as a data visibility and analytic advisor. Well, my main role within the Minister of Health was to support on establish, data use culture in order to improve decision-making based on evidence. And I have almost 11 years of experience in this field. Thank you. Over to you, Barbara.
Great, thanks. All right, so today's webinar is the 3rd in our series, and I hope you will be able to attend the other webinars in the series that are listed here. And I'll provide more information on those and on the remaining webinars in my follow-up email to you. And as always, and I see many of you have already started doing this, please take a moment to introduce yourself using the chat function. Tell us your name and where you're from. And then we hope to have time at the end of the webinar for questions. And so if you have a question during the webinar, please use the Q&A function that is at the bottom of your screen. Now on to today's webinar. I just want to give you a brief intro to what we're going to be talking about today. We're going to talk about data triangulation and how it can be used to strengthen immunization supply chain at national and subnational levels. We're going to be defining data triangulation and give you some examples. And of course, we're going to have a great example of the Mozambique data triangulation activity. In that Mozambique example, we'll also see indicators as well as data and data sources, and we'll talk about those as well before we get into that presentation. We're going to point you to some tools and resources available to help you do data triangulation activities. Now let's go over to Adriana, and she can kick off our discussion on data triangulation.
Great. Thanks very much, Barbara. And thanks again to all of you for joining today. So let's spend a few minutes up front just talking about what data triangulation is. So here is our basic definition. Triangulation is the synthesis of 2 or more existing data sources to address relevant questions for program planning and decision-making. Chances are you've already done data triangulation in your work. It requires critical thinking and some basic analysis skills, but this is really not just about making graphs. It's about turning data into reliable information that you can act on. So it helps us identify the limitations of any one data source or data collection methodology, and it gives us a process to be able to address those limitations. Data triangulation encourages deeper insight through complementary information. So you can make sense of what is happening by comparing different sources of information, as well as having an understanding of the broader context. So for example, if you were concerned about the quality of your dispense to user data, you might compare that data with issues data and service data to see if there's a relationship between all of that data and whether they're aligning as expected. And this might lead you to an action to help improve the capture of dispense to user data, which is, as we know, a critical data item for all supply chain functions. So let's dive a little deeper with some examples. So now that we understand that data triangulation involves bringing together 2 or more data sources to address a question or a problem within a health program or within the management of health commodities, let's consider how data triangulation can help with immunization supply chain management. So just a couple of examples to get us started. So like the previous example I was mentioning, it can help us understand and identify possible data quality issues. So for example, if you compare the doses issued of a vaccine to the doses administered, as well as the stock on hand, that information is complementary. So you'd want to understand, how aligned are the doses issued to what's been administered and what you have left in your stock. So if you compare program and supply data in this way and see discrepancies, this can help indicate some data quality issue that might require action. So another example is that data triangulation can also help you understand why you might be seeing certain trends in the data. So for example, imagine in the past few months, you've noticed a higher wastage rate of measles vaccine. If you're solely looking at your LMIS data, it may not tell us exactly why we're seeing this upward trend, and it might even be a concerning trend. But imagine if now you also reviewed microplans and you realize that in this area, there's actually been a change to conduct daily immunization sessions rather than weekly. And therefore you're opening a vial every day, even when, there may be one child to vaccinate. And if this were the situation, it would change it completely. This would be an example of a good reason, right, to see increased wastage or a justified wastage. So the action that you would take might be totally different than if you were just looking at your LMIS data. So the data triangulation process overall, we can think of as a 4-step process. So this process has been outlined in global guidelines for data triangulation, which is a resource that we will share with you at the end of the webinar. And so, okay, first, the first step is that you want to ask the key question. Second, you want to identify existing data sources. Third, you summarize the data and local context. And lastly, and arguably most importantly, you want to develop an action plan. So let's dive into each step a little bit more, thinking about that previous example. Okay, so step 1, ask the question. You want to start by identifying what is this programmatic problem or question that you have. The question has to be something that is actionable, something that you'll be able to answer. And so using our previous example, the question might be, why is our measles wastage rate higher? Okay, so then you have step 2, identify existing data sources. You should identify the relevant data sources to help you answer your question. So this doesn't need to be something overly complex. You should really be focusing on data that is readily available to you. And you want to consider the strengths and the limitations of each of those data sources that you're considering. So for example, we might, looking at our example before, we may be looking at data in both the LMIS as well as, the microplan at that district facility level. Okay, so then you have step 3, summarize data in local context. Here's where you're doing the analysis. You're going to be evaluating trends in the data. You're going to be brainstorming hypotheses to try and understand or explain those findings. And you're going to want to incorporate, local context and local knowledge to help round out the information that you're seeing. So at this step, you may prepare a presentation that summarizes your findings. So essentially in this example, it would be that there is now higher wastage, but it's actually because, we are opening vials to vaccinate every child, and we're making sure that services are actually accessible more often than they were before. Okay, and so then last is step 4, develop an action plan. So ultimately, the whole point of doing a data triangulation analysis is to lead you to step 4 and to lead you to greater insights to be able to determine the best course of action. So, what decisions or what actions should we be taking based on what we've learned? So you should be developing concrete recommended actions to take, and you should be engaging the stakeholders who will need to take these actions. So in this case, it may be that you adjust the target for wastage. You may also need to consider whether you need to start supplying higher quantities of vaccine to this area in order to continue to meet demand. And so that action plan is something that should be discussed and decided upon in consultation with those stakeholders. Okay, great. So I want to take just another moment to dive a little deeper into step 2 of the process. So once you have asked your key question, then you want to go to step 2, which is to identify existing data sources. So we have some examples here to get some ideas going about what are the readily available data that we may already have on hand. So these are just some examples. I won't go through them one by one, but some or all of these data may be available at your level within your country, right? So you may have service data available through DHIS2 or some other data source, LMIS, microplans, supportive supervision checklists, other assessments. So there could be many things that are available. And so you want to start to identify what is there, what do you have access to, and then what makes sense to use or to look at depending on your question. Great. So, and when we look at even at the health facility level, there's a number of data sources that health workers are using on a daily basis that can be triangulated against each other in order to improve data quality as well as decision making. So even just in this photo, you can see lots of data that the health worker is recording. So we have the tickler file, and that is used to track when a child is due for vaccination. We may have the home-based record or a child health card, which is what the caregiver is bringing to the session. We've got the immunization register, and that helps record the doses by name. We've got a tally sheet by antigen to record, the number of doses given. And then you have the stock ledger to be able to record the stock. And so you can probably think of at least a couple of other sources of data that aren't pictured here as well that may be available at the health facility level. So the idea here is that, many of these data complement each other. For example, a health worker can cross-check information in the stock ledger and the monthly report to be able to determine the supply request for the following month. So when these various data sources are used together and the data entries are up to date, then they really can help provide a complete picture of the vaccination program at the facility level. So, data triangulation analyses can be done either routinely or in an ad hoc manner. And it can also be done at various levels of the health system. We've just seen, at the health facility level, but you can also do this at national level, provincial, district, at all levels. So what are some opportunities to incorporate data triangulation to better manage supply chain performance? So we want to hear from you. Please type in the chat some ideas. So what are some examples of routine reviews of supply chain performance? What are those opportunities where data triangulation could possibly be incorporated? And we'll give you, maybe just a minute or so to respond.
So we're looking in the chat and hoping to see some of your answers.
So you can think through, are there certain regular meetings, for example, where you might be reviewing supply chain data?
So Greg has mentioned monthly or quarterly data review meetings at district level.
Great.
Lakesh is coverage and vaccine utilization.
Those are some examples of data that you could be comparing.
Annual vaccine forecast. Anojo has offered that. And one of the questions that Idajiak has asked is speed of vaccination and stock level, also distribution, vaccine utilization. So we've gotten some interesting ideas for some issues to look at and some indicators to look at.
Yeah, definitely. Okay, great. So thanks everyone for your ideas. Yeah, quarterly review meetings at various levels, monthly ordering. Great. So yeah, so just like all of you have mentioned, we just put a few examples here of opportunities for routine reviews where you might be able to incorporate data triangulation or where you might already be doing so. So, as was mentioned, annual forecasting at national level, monthly data review teams at various levels. I think we've presented in the past on impact teams and how those monthly meetings they could incorporate data triangulation. Vaccine requests at a health facility level, and quarterly deliveries and distribution at provincial or district. So just some examples, and I can see we've already got more from you. So that's great. Keep it coming.
Thank you, Adriana. We're going to now turn the webinar over to Mateo, who is going to give us a presentation on using data triangulation to improve vaccine availability and coverage in Mozambique. Take it away.
Thank you, Barbara. Well, hi again, everyone. I'll be presenting the data triangulation example, Mozambique. But before that, I think it's important to point out that the expanded program organization in Mozambique has made significant contributions to reduce infant mortality through its service in the recent years. But this success most of the times, depends on, the existence of adequate amounts of vaccines, in particular at the health facility level, in order to vaccinate and immunize children. But on other turn, this also depends on, a functional logistics system that's still, a challenge for the country. So this presentation, aims to illustrate how we can use, data triangulation in order to improve vaccine availability and as well coverage rates, taking the, the API in Mozambique as the case study. Can you move on? Well, as the first step of this work, the API Vial team in Mozambique, based on coverage data analysis, they defined the question that they wanted to be answered through this data triangulation exercise. So at the time, the program had low performance, in some of each indicators. But the main question that, was intended to be answered was if stock availability was the primary factor affecting, low vaccination coverage for the period under analysis. And in case yes, which antigens contributed to the low coverage? So the API and Vial team, decided to use data triangulation because, they see this method as an, efficient way of synthesizing and analyzing, multiple indicator types that could help to, identify, factors which were contributing to low vaccine coverage and perhaps poor API performance in Mozambique provinces. Well, when developing this work, the API and Vial team in Mozambique encountered some challenge related to data access, since it was not possible to access logistic data for the health facility level in some provinces. So the team also found other constraints related to population data in order to estimate target groups. That most of the time this data was inaccurate for some provinces. But successfully through this exercise, the API Vial team was able to identify, specific antigens that, were in its turn, stock availability was affecting coverage rates, and also identify provinces with low vaccination coverage in order to, draft action plans. Please move, Barbara. Okay, so for this work, there was a need to involve 3 people, one data manager and one M&E officer from the Ministry of Health, but as well one, data and analytic advisor from VillageReach. This work took approximately 10 hours per week for a month, mostly because the team had other tasks to do. But I think it's important to point out that the more you practice data triangulation, the more experience you gain, and the time to perform this task tends to decrease because you already know the process. So the data analysis for this work is from January to May 2020, including the December 2019 for logistic data. And for this work, there was a need to access about 7 data sets from different sources such as SELF, SMT, DHIS2, and the team used the Excel as the basic software for data analysis. Well, in these slides, we have the key consideration that the API Vial team needed to think through when conducted the data triangulation exercise. We found that there was a need to have a mastery of the API indicator in particular, but there was also a need to know the logistic process at all the levels, to know as well the program context and the country context. Okay. So the data sets that we used for the analysis were, as I said before, SMT, SELF, DHIS2, including the census data. Note that SMT and SELF are logistic systems and tools that allow us to visualize national warehouse stock availability, in this case for SMT, and to visualize the health facility stock data for SELF. But it's important to point out that SELF data are collected during the monthly vaccine distribution at health facility level, And in case this distribution doesn't occur, the stock data at this level are not collected. In its turn, DHIS2, among several health information, allows to visualize the number of, children who were vaccinated in the different antigens, but also allows to visualize the reporting rates of the vaccination data. Census data, in its turns, provides the target groups to, calculate the, the vaccination coverage. Well, for the national and provincial level stock analysis, the API-1 team used SMT in order to look at the stock levels data to check if there were stockouts and also to compare with the vaccination data. Again, to see if they may have affected the coverage, in particular at the health facility level. So as a result, the team found that at the national level, rotavirus and BOPV, as we are going to see in the next slides, were the vaccines with stockouts during Q1 and Q2 2020. For the health facility level, the team looked into the stock level data to understand the vaccine availability, and again to compare with coverage data. As a result, the team found that some provinces registered high levels of stockouts for most of the antigens, but on the other side we had provinces like Zambezia, Niassa, and Maputo, as we're going to see in the next slides, that how the visit rates for vaccine distributions were low. Please. So during the analysis of the national level stock data, the team looked into stock levels available for Q1 2020 in the left side, and for Q2 2020 in the right side. The left chart indicates that rotavirus was the vaccine with imminence of stockouts, and probably the stock available of the vaccine was not sufficient to cover the country needs for Q1 2020. And we have the same situation in the right sides, where BOPV had insufficient stock level to cover the country need for Q2 2020. So yeah, this is. So in order to access the stock availability at province level, the team had to review the stock levels. But before presenting that, it's important to highlight that the country have 11 provincial depots that are represented here. So in the analysis of the stock availability for Q1 in the left chart, similar to what happens in the national warehouse, it is noted that several provinces had stock availability below 50% for rotavirus vaccine. But for Q2, as we can see in the right chart, also similar to what was recorded in the national warehouse, BOPV was the vaccine that registered low stock availability in most of the provinces. For the health facility stock data analysis, the team first analyzed the reporting rates of stock levels, which on the other hand, this means the number of health facilities that were visited for vaccine distribution, and as well stock data collection. It's important to note that the stock data is collected during the monthly distribution of vaccines, and the more representative this data is, the more accurate the analysis of stock data becomes. We can easily see that provinces like Zambezia, Niassa, and Maputo had registered low rates of health facility visits for vaccine distribution, and as well the data collection. So the API-1 team had to use this data in those provinces cautiously, since it was not very representative. So, after reviewing the completeness of stock data, the team analyzed the vaccine stock data at health facility level. It can be seen in this table that, rotavirus and BOPV were the antigens that most registered stockouts at the health facility level. We also had, stockouts on other, in the remaining antigen, but with smaller proportions. Again, not that, we only have 10 provinces represented here, but the country has 11 provinces. Since Nampula province is not here because South had not yet been expanded to this province. And South was the tool that was used to, collect the stock data at health facility level. Well, okay. Well, in this slide, we bring the findings for, the stock data analysis. We could see that, at national warehouse, there was a stock out of rotavirus and BOPV vaccine. While at the province level, the stock availability of rotavirus and, BOPV was low, in particular in some provinces in the north of the country. Some of the provinces has high amounts of vaccines, in one quarter, and low amounts in, the following quarter, and vice versa. So this was one of the findings we had. The other findings was the, majority of the province health facilities were visited, as we could see, for vaccine distribution as well, data collection. But we had, Niassa, Zambezia, and Maputo province with low rates of health facility visits for, vaccine distribution and data collection. On the other side, majority of provinces did not have significant stockouts at health facility level, except to Cabo Delgado, Niassa, and Zambezia provinces. On the other side, again, in the health facility level, BCG, BOPV, and rotavirus were the vaccines that had experienced most stockouts at this level. Well, now that we have analyzed the stock data, we are going to move to, the coverage data analysis. In the next slides, including this one, we will try to answer, the question that, we raised in the beginning of this presentation. Essentially, we want to find out if stock availability was the primary factor affecting the low vaccination coverage, and in case yes, which antigens, contributed to the low coverage. So in this slide, similar to the logistic data analysis, the covered data analysis, the team first, started to analyze the reporting rates of the DHS2 data in order to understand the completeness of immunization reports, but also to identify, location with potential reporting issues. Well, the team compared the reporting rates with coverage data and found that, all the provinces had acceptable data reporting rates, which they ruled out, the lack of reporting on interfering with coverage rates, with exception of Cabo Delgado province, as we are going to see in the following slides. But, after analyzing reporting rates, the team also looked into the coverage data to analyze, program performing using the K, immunization indicators. One of the main findings that the team had is that, most of the province had acceptable coverage rates for the different antigens, with exception of rotavirus and BOPV. The team also could learn that, stockouts at various levels did not have a significant impact for BOPV coverage. Next slide. Well, in terms of DHS2 immunization, data reporting, we can easily see that, Cabo Delgado province were the only province that did not reach it, the desired target. Okay. Well, to analyze the, the covered data, the team first analyzed the first doses of the, the vaccines given simultaneously in the left chart. And we can see that with the exception of Cabo Delgado and Maputo provinces, all the provinces had, coverage rates within the country targets, in particular for BOPV, Penta, and PCV. Next, the team analyzed the third doses in the chart on the right side for BOPV, Penta, including, IPV. And, in the chart in the left side, Cabo Delgado, Maputo provinces registered the low coverage for most of the antigens. On the other side, we had provinces like Inhambane, Gaza that had, extremely high coverage rates, which suggests problems in the data quality. The BOPV, which suffers stockouts at various levels, was not affected in terms of coverage, as we can see here. Well, after analyzing the first and the third doses of vaccines that are given simultaneously, the team individually analyzed the first and the second dose of rotavirus. And it was found that the province of Cabo Delgado, Nampula, and Zambezia had low coverage rates, which suggests that they were severely affected by the stockouts of this antigen. Once again, it's noted that Gaza, So once again, it's noted that Gaza and Inhambane provinces recorded extremely high coverage, and we had again Maputo province with low coverage rates for this antigen. Well, in order to understand whether or not there was children who were not complying with the vaccination schedule, the team analyzed the dropout rates for some antigens. In this case, as we can see, PCG registered extremely high rates of dropouts in all of the country, but we also have rotavirus vaccines that register higher, rates in the province in the north of the country. So, note that, due to the change of some policies within the program, we have also PCV that, registered high dropout rates. And this was mostly, related with the fact that there was a change in the, calendar, vaccination calendar for, for PCV, that it's now being given at 9 months of age of the child. Well, this slide summarizes the performance of the program, using the different indicators. And, the map presented here clearly shows that, the provinces that registered rotavirus and BOPV stockouts had the lowest coverage, in particular for the, the indicator full immunized children. On the other side, the table on the right illustrates that rotavirus vaccine had the low coverage, including, PCV that we already mentioned, the reason behind. But I think it's also important to, note that the second dose of measles that also registered low coverage, it's now given at, at 18 months of child, and was, introduced in the country in the, in a few years. So it's still on a process of being routinized. Next slide, please. So, so we have just analyzed that, in fact, stockouts have, severe impact on coverage for some provinces. So we think that keeping vaccine available at health facility level, it's extremely important for a successful vaccination. Well, now that we have done with all the analysis and we have great findings to present here, the team took each finding from each data source and tried to come up with the root cause and recommendation as we are going to see here. Well, in order to better understand, the underlying reasons for the problems that we found, The team performed a second exercise to find the root cause analysis, to find the root causes, and also suggest some actions for the API management. Well, starting with the stock data source, it was possible to understand that the stockouts of BOPV registered in particular in the national warehouse is due to the fact that BOPV is purchased by the government, and due to inadequate funds and including accumulated debits, the suppliers do not ship the vaccines before the debits are settled. In its turn, causing stockouts at the national level, and again, insufficient stock amounts at the subnational level. On the other side, rotavirus has similar reasons, has BOPV, but in its turn, rotavirus vaccines are being funded not only by the government, but as well by the donors. And the donors use a non-government approved method in order to calculate vaccine needs, which for some reason underestimates the real needs in the country, causing stockouts at different levels. Well, during this exercise, the team also realized that the vaccine distribution are not standardized, which in particular at the national level, which causes distribution to be done in an ad hoc basis, affecting the vaccine distribution as well at the subnational level. Next slide, please. Well, for the findings on coverage data sources, Cabo Delgado was the provinces that registered low coverage on most of the antigens. And this was due to the, mostly by, the political instability and conflicts in this province that leads, to closure of several health facilities and, remaining with many children unvaccinated. On the other side, there was a low coverage of rotavirus at the at the national level, and in the province of the north of the country, due to insufficient amounts of rotavirus received by these provinces. Next slide, please. Well, for the findings on the census data source, the team found that the population data was inaccurate for some provinces. There was a problem with the denominator that was underestimated or overestimated for some provinces. And there was a low coverage of the third dose of PCV due to the change, as I mentioned before, on the policies within the program. Well, we have to say that I think we reached the end of the presentation, and we have to say that this was a great process and experience, and we could understand more about the program and also about the underlying root causes that are affecting the immunization coverage in Mozambique. So this is an activity that was embraced by the EPI VAN team in Mozambique, and it has been very useful in order to improve program performance. So yeah, thank you. I think we reached to the end slide, perhaps. Thank you, and over to you, Barbara.
Okay, thank you so much, Timoteo. We will have a few moments for questions in just a few minutes, and many thanks to you and your other colleagues at VillageReach for that presentation, which I found very interesting. Before we finish our webinar and move on to questions, I would like to point out a number of resources that we will share in the follow-up email. The first one is a guidance that was developed by CDC, UNICEF, and WHO in 2020 on using data triangulation for program improvement at both national and subnational levels. It's available in English and French, and I know many of you often get back to me and say, why don't we have things in French? But this is available in French. So this comes with recorded webinars and slides for training on data triangulation as well. So I'll share the link to this resource for you. And then there are two other resources here that'll be found on JSI's website, which I will share these links. And we'll have more resources for you after next week's webinar when we continue this discussion. On to our last slide. We have had a chance now to talk about data triangulation, the process, defined it. We've looked at a few indicators and data sources, and we've looked at, and I've shared a list of tools. And so now we're going to take some time to address some of your questions. And there were quite a few questions, and I encourage you to please, there's some questions that came up in the chat, but if you have questions in the chat, please go ahead and put them in the Q&A if you can, please, because that way we have a record of them and we can share these questions and answers with you. Before we end the webinar today, I want to make sure that any questions that are specific to Mozambique are answered. And one of the questions that maybe the Timoteo or the VillageReach team can answer is, are there any other factors that contributed to low coverage rates aside from stockouts in these districts and facilities? So feel free to open the panelists or anybody, Timoteo, to open your mic. Were there any other factors that contributed to the low coverage rates?
Oh, yes, I guess, yes, there are many other factors. As we could see now, we also had low coverage rates for the second dose of measles that is now being given at 18 months. And we could see that there is a missed opportunity of vaccination within the health facility level. The mother can take, the children to other reasons for the health facilities, but doesn't pay attention, for instance, to take the child to be vaccinated for the second dose of measles. So missed opportunity is also one of the reasons that, exist that contributing to low coverage as at that level.
Okay, great, thanks. There's another one related to Mozambique specifically. How have the API managers in Mozambique been able to use this data to influence decisions? Or are there any processes or steps they follow to drive data use for action? Briefly share some examples of the decisions they made, actions they took, or that led them to change to improve EPI programming. And he's curious about how government is driving data use for action as part of their commitment and ownership of API data. So really focusing on that fourth step of the process.
There is a VAN team, which is, they used to, periodically, they used to sit to analyze, the performance of the program. So for this case, in case of, data triangulation, they do not do this every month. They used to do it, every 6 months, 3 or 6 months, in order to review the performance in a given period, and also supporting the decision based on evidence to, influence in some policies change. We could see that, the stockouts of rotavirus, or if I'm not wrong, they were mostly being affected because the donor that is supporting this vaccine, use its own methods in order to estimate the country needs. So based on this exercise, the team, based on this evidence that we saw in the presentation, the team used this information in order to, influence the decision makers to advocate with the donor in order to change the way they are estimating, the country needs, in the sense of, having the country receiving the adequate amounts of vaccines and, reducing the stockouts that are being encountered, in particular in the vaccines that are jointly being purchased with the government and as well with the donor. So this is just an example of how these, data triangulation are being used in order to, change or even improve the program performance.
Thank you. Very interesting. Greg has a question, a fairly simple question to answer about Mozambique. Are the data sets manual or automated?
Oh, well, fortunately, most of the data sources are automatically. Yes, from the logistic data sources to the coverage data, all of them are automatic, are being captured automatically.
Okay, so they're automated. Okay, great. There are many other questions, so we're going to deal with some. I think, Adriana, you wanted to answer this question: how the nature of vaccine dose per vial presentation affected your immunization coverage. Adriana, do you want to come on and answer that?
Yeah, sure. I guess I just wanted to kind of touch on this great question. JSI also has some resources related to this. I think, what we've found is the number of doses per vial or the doses per container, can have an effect, and essentially it entails kind of balancing trade-offs between, coverage targets, wastage, costs, supply chain space, health worker behavior. There's a whole host of factors that go into determining, what makes the most sense in terms of higher or lower doses per container. And I just wanted to share, I can put a couple of resources actually in the chat that kind of summarize that kind of relationships and some examples of good practices as well. So I'll go ahead and share that link in the chat.
There was a question that actually got some discussion going in the chat, which is there any relationship between immunization coverage and wastage? And does anybody want to comment on that? It's sort of related.
Yeah. So, I mean, I think I touched on this as well. I think it certainly depends. I think it depends on the situation, and it depends on the type of vaccine that we're talking about, right? So, so in the example that I had shared with measles, which has, it has to be discarded, essentially the same 6 hours after opening, right? Whether or not all 10 doses, in most countries they have a 10-dose vial. So whether or not those 10 doses have been used, you have to discard after 6 hours. So in that case, if you are, well, basically, what we encourage as part of the EPI program is that you should open a vial for every child. Now, does that happen everywhere? I would say no. And I think a lot of times there might be kind of fear to open a vial from health workers. That's what we've found that in past studies, due to kind of a fear of high wastage. So I think there's, it's a bit of a balancing act, but I think that's why, particularly communication from supervisors is so important, right? So that just because there may be what you might consider to be, high wastage, that's not necessarily going to be a bad thing. Right. So it depending on the characteristics of the vaccine and the practices and a whole host of other issues, I don't think it's a simple kind of equation of where, that you should see, a certain kind of trend for a certain, for one vaccine or another. I think it's really kind of dependent and a bit more nuanced.
I think, thanks. And the resources that you mentioned, we'll put those in the follow-up email so that everybody gets them. So you don't need to worry about putting them in the chat for now. I think this question is related to Mozambique, and I want to make sure we get to it before we finish today. Are vaccines distributed to the lower level based on requirement? And are there available storage facilities at all levels in the system? And I think this is related specifically to Mozambique.
Oh, yes. In case, yes, the vaccine distribution at health facility levels depend on some requirements, such as the population of that health facility, the average consumptions of that health facility. But not that, Mozambique uses, a distribution process level direct to the health facility based on the requirements that I just presented.
Okay, and are there storage facilities at all levels? And does the health center have storage there?
Yes, yes. Most of the health facilities have, fridge to store,
Okay.
refrigerators.
Okay, refrigerators at the lowest levels. Okay. There was a question that I think, Adriana, you wanted to answer live, which was about how to triangulate stock receive versus stock management, how to go about reviewing data in the stock ledger versus DHIS2. Do you want to go ahead and answer that one, please?
Yeah, sure. And I think there was also kind of maybe another question that was kind of similar of just wanting to understand, what to look at and how. So I think what I would say is that, depending on what level of the health system you're looking at, as well as, what does the data flow look like for your country, I think you may or may not have certain data available, and digitized to be able to compare easily. So I think it really just, it kind of just depends on your country and what the context is there. So I think overall, what I would say is, I would encourage, everyone when you're thinking about this is to focus on, what's available and what's easy to work with, right? So if, for example, you are conducting supportive supervision at a health facility, you could compare ledgers and tally sheets and like all of those kinds of data sources that we touched on that are available at facility level. You could do that, in the context of supportive supervision. If you're, for example, working at higher levels and you may have LMIS data and DHIS2 data that are digitized, and that could be, easily exported to Excel or looked at, in some other way together. If there's a way to kind of bring that data together easily, then you could try that. So I think kind of, overall understanding the data availability, the accessibility, and then as well as, how easy is it going to be to prepare and use the data for analysis. I think all of those considerations are really kind of an important piece of that kind of step 2 of the process where you're identifying the existing data sources. And then actually maybe, Barbara, if we have time just for one more quickly, I think there was another one that was about kind of the strengths and limitations of data sources. Sure. And they had asked, which data on which source or indicator
do you rely on more?
What do we rely on more? I mean, I think that's, that's the key question, right? So I think, again, as unsatisfying as an answer it might be, I think the answer is it depends, right? And I think all of you are probably in the best position to know, what kinds of data sources do you have a sense are more reliable? And then there also may be ways to kind of test that quality of that data source by doing triangulation. So for example, I think Timoteo in his presentation talked about comparing data on, vaccines that are supposed to be administered at the same time, right? So if you're supposed to be administering Penta-1 and PCV1 on the same day to the same child, right? They should be receiving that on that visit. Well, how well does Penta-1 and PCV1 data line up, right? And if they don't, well, then you already know with that admin data, you may have, an issue. So I think understanding kind of what might be reliable and how you might be able to tests that reliability is also part of the process.
Great. We're going to end here, and there are a few questions that haven't been answered, and we will do those offline and include them in the follow-up email with some answers. But I just want to take this a few minutes to remind you, we'll be getting a follow-up email. It'll have the link to the recording, the slides that we used, and we'll answer some of these questions. And I want to remind you that next week on February 1st, at the same time, we will continue this discussion of data triangulation. First, by looking at how Ethiopia has used data triangulation and does so on a routine basis. And then we're going to be doing an interactive exercise with you all to explore how you can use data triangulation. So we hope you'll be able to participate. I will put information about that in the follow-up email. And as a reminder, anyone who attends 5 of the 6 webinars in the series, either live or recorded, will receive a certificate of participation. So many thanks to all of you for joining us today, and have a good rest of your day. Take care.